An Oxfam South Africa report has revealed that government's underinvestment in public healthcare and profit-driven private hospitals has resulted in the exploitation of healthcare workers. It further found that the healthcare system is ill-prepared to deal with the COVID-19 pandemic. According to the report, 84.6% of the population relies on public healthcare facilities. It also noted that it would take a nurse 65 years to earn the annual salary of the chief executive of a healthcare facility. For more on this, we're joined by Western Cape Health MEC and qualified nurse, Dr. Nomafrench Mbombo. Good evening, and thank you so much for your time tonight. Certainly, as one reads that intro, it looks like even on a day like this, the struggle of the nurses continues.
Oh, yes, indeed. Especially now during the COVID. But remember, the challenges have been there even prior to the COVID. So because some of us, when we even move from the clinical setting and go into academia, teaching and research space, it's not necessary that it was necessary a first choice. We would have wanted to stay more next to the bedside of the patient. But in order for anyone to earn more salary and also to get promotion, it means that we have to move the bedside and go to that space. So unfortunately, indeed, it has been like that. And in as much as that we are getting, even previously, as many of people interested to do nursing, but to do sometimes feel that others get demotivated, especially in regard to the workload that is happening now, especially with the COVID, and also with the trauma and all of those. But in spite of that, our nurses throughout the COVID, since 5th of March, in the province, since 11th of March on our first case, they've been there throughout.
And when one then looks at what you're saying, you know, around the fact that they've got to go elsewhere in order for them to have some of their ambitions met, particularly on a financial aspect. Does this then, underinvestment into this particular sector, then make things difficult to retain some of the nurses that could then have the necessary experience when it comes to resolving some of the most complex situations in hospitals?
Yes, of course, it is difficult because with a brain drain where we, most of our nurses, for example, go to the UK and the UAE, and mostly those who would have had specialties like the ICU, theater, and all of those. Just like, for example, now with the issue of the COVID, the critical care space in regard to the critical care beds is not only about the number of beds, but to get a qualified ICU nurse, it becomes difficult because you have to train them longer. So it's not about that you can have a 2-week course and then you get them there. It's quite long. So it does have an impact in regard to that. But noting that with South Africa also, with the changes that are coming through the qualification, it also does quite make such confusion where you are being told that you are still sticking to the old legacy qualifications, where some of them had shortcomings in regard to the preparation for the nurse in the current context. Also in regard, as you indicated, that about the remuneration, which is even then, during the time that the South African government introduced the OSD, which is the occupational specific dispensation in regard to the qualifications of nurses, even that, because it was supposed to be revised in 2017, there were some gaps in regard to some of the positions, like the clinical nurse specialists that were lacking there, and meant that people were trained to be occupying those positions, but they were never filled in regard to that. But again, we also need to consider in regard to the role of the organized labor, because nurses have got as many of the organized labor, the unions, where they are the members of, for example, the DINOSA, the NEHAU. What is the role they play in the bargaining chamber, because this is happening at a national level in regard to the remuneration of the nurses, especially in regard to their specialties. So we have to look at it broadly.
And it looks like then they might find themselves, as you say, the unions, what are they doing in the remuneration space? But we have been talking to them about this public work, wage sector, agreements that, is even not yet been adhered to, and there's even threats of a possible strike as we're finding ourselves at the cusp of a third wave. Certainly then it looks like the unions, even themselves, may have their hands tied here because it looks like government is not willing to move an inch.
Yes, if we're talking about now, it could be like that, but again, the unions have been there even before. I'm talking specifically in regard to the OSD and the positions and the remuneration in regard to those positions, and around the whole of the profession itself in terms of the entry point in regard to the remuneration. It has always been there. This should have been fought even during that time, because it cannot be when we have to train somebody for 4 years, because during our time it was taking actually 4.5 years. For 4 years, with almost more than 4,000 of the clinical hours that the person has to spend, the minimum actually, in a clinical setting where they become part of their shifts. So whether you are doing second or third year, it means that you still have to become, whether it's, for example, night duty and all of those. And yet, noting that now there's no remuneration even among the students because they have bursaries. So the issue, it has always been there. But with the COVID, what you have seen, the majority of healthcare workers were affected and infected, were nurses, and even those who died were nurses. And yet we're still relying on them as a backbone and the heartbeat of the health system to be there no matter what.
And talking about them being there no matter what, certainly as they highlighted even on a day like today about the long hours they have to wait, to work around even some of the dangers that they face themselves, because some of them are saying that they don't have even things like PPE, in order for them to then be protected because they are in the front line. What then, where do they go, particularly when you look at the fact that right now there's talk of a third wave, we're seeing COVID-19 cases continuing to rise, and a system that has been exposed by the pandemic itself to even further scrutiny when it comes to its weaknesses?
In the Western Cape, for example, at the time during the first wave where there was an outcry about the lack of PPEs, and then we realized that it was about some people felt that the current allocation or the type of PPE that is being allocated to that particular setting is not enough. It's not necessarily that there was a lack of. I used to say that if it so happened that a certain type of PPE is required for a nurse or even for an EMS or any other health professional, and then they found that it's not there, they've got the right to sit down or choose down if there is no PPE. You cannot be in an environment where you don't have the tools. You have to have the tools, just like a pilot. If there's some of the difficulties or challenges or faulty in your engine, you cannot fly the plane. But as I indicated earlier, because the COVID was new, nobody knows how the pandemic evolves and all of those. In some instances, it was about when there was expectations around to have a full moon suit, which even in some instances like ICU was not even one, but except in COVID ward. But we ended up coming up with the regulations and the circular where it does stipulate clearly that when you have a patient facing in different settings, or when you are not patient facing and all of those, what kind of a PPE that needs to be worn. Of course, as science keeps on reflecting, giving us more information, for example, in the labor wards, initially there was no full PPE that used to be worn at the time, until research did show that when you are in the second stage of labor, that's when actually there's a high level of infection. Therefore, you must be full PPE. So that's even now, I can say it now that if there is no PPE as is required in a particular setting, no healthcare worker should even start working, because it does have a huge, not only impact on that particular health worker, it means that you are prone to even to spread the infection to others, especially your patients and also your colleagues surrounding you. But we shouldn't be now actually be talking about not availability of PPE. because this is a new budget here, the provinces themselves and also some monies from the national, they're supposed to have bought as many PPE that is required in preparation for the third wave. It cannot be that you end up prioritizing things that are unimportant and then at the expense of when we know that the pandemic is there.
And should we then be looking at a resetting of the system that could then see, newer models then being introduced into the healthcare space that could see nurses at the center of healthcare in the future?
They should be, but they are the center of the healthcare, but also, as I indicated earlier, it's multifaceted where you find that even the nursing profession itself, in regard to an input in regard to the education. I made an example that in order for you to earn more salary and also to get more recognition in regard to the promotion, it means that you have to leave the clinical area. You have to leave the bedside, the patient bedside, where you have to have all these qualifications and then being an administrator and manager. Yet, how it's supposed to be, you should be able to have different streams that prepares you to be sitting at the bedside where you want to. So it goes back to the nursing fraternity themselves in order to fix it.
And is the wellness of particularly nurses taken into account here? Because when one looks at the pandemic, some of them have had separation anxieties, particularly at the fact that they've not been able to see their families for extended periods of time. They don't have even sometimes a good support system. Would you say that their mental health has been taken into account?
Not really, especially at the beginning, but things are changing in regard to have the counseling at the workplace, not necessarily being centralized elsewhere. That is in addition, and also to be given space for them to, in terms of reflection, but noting that in most instances, it's not only, or let me put it like this, the psychological impact is not only about what affects them as individuals or as clinicians or where they are working, but the mere fact that when you have the care that you are supposed to render, it's not, you feel it's inadequate. You call it moral injury, where you find that when you have to care for people, you have to make a decision on which one that you prioritize over each other one. For example, then when we had a situation where we have got fewer, for example, the oxygen outlets. And also that, for example, because with the nursing, you are not only nursing a patient as an individual, you also nurse the family and the community. The situation where in our hospitals, the families are not allowed to visit the patients, their loved ones. It meant now the psychological support has to come from the nurse who's nursing that patient, because the patient might not be progressing because is psychologically and mentally affected that the loved one is not there, and then some dying all by themselves. So going up to that level where you need to bring the video cameras in some instances is part of bringing the healings. It's about bringing the care. So it does have an impact to you as a healer and also as a carer if you find that you feel inadequate to provide as much care as you require, because we have to provide holistic care.
All right. Thank you so much for your time tonight. That was Western Cape Health MEC, Dr. Nomafrench Mbombo.